So blood vessels and blood pressure. And I'm sure you've learned some of this physiology. So we're going to try to give you as much anatomy as I can today. And we're going to do this in a 2-week lab, so you don't have to learn everything. So I like this. First of all, let's get the definitions here between arteries, veins, and capillaries. And we'll go through each of these because these are really important. So arteries are any vessel that takes blood away from the heart. It's a vessel. It's a roadway. Takes blood away from the heart. Blood. And we know what blood is now. You know everything about blood. And the veins drain back to the heart. Vessels. It's about blood, right? So back to the heart is veins. Back to the heart. So veins drain. So you got to be careful, though, when you do the heart. This is why I'm not telling you oxygenated versus deoxygenated blood, because in the pulmonary circuit, the arteries coming from the heart are actually deoxygenated. So I can't throw that oxygenation business in here now. Same thing with veins. Coming back from the lungs in the pulmonary circuit, the veins are actually oxygenated. So that's that contradiction you gotta hang on to, because that's the questions you'll be asked. Pulmonary circuit. So the other circuit where arteries are oxygenated and oxygenated blood, oxyhemoglobin, glows red. So in the systemic circuit, that makes sense. Arteries are all red, arterioles are red. In the systemic circuit, veins are deoxygenated blood and they tend to be more bluish. So that's reduced hemoglobin, or it's not oxyhemoglobin anymore. It's free hemoglobin, you can call that. So ultimately, the arteries are going towards the capillaries, and there's an in-between called arterioles. And that's going to the capillaries. So the capillaries are just basically one layer of endothelium with a basement membrane. No muscle layers, right? And these are simple squamous epithelium because they're porous, right? So the endothelium is simple squamous epithelium, and that's for diffusion. That's why they're porous. So you have that exchange of substances, especially gas exchange. And of course, fluid and other nutrients and your ions and other things that go into the interstitial space, like hormones, white blood cells, antibodies, carriers. Okay, so when you come to the veins from the capillaries, that's called the venules. So they're just cute little veins. So you have an arterial end of the capillary and you have a venule end of the capillary. So capillary, I can't say oxygenated or deoxygenated because it's in between. So that's really important. And these are the 3 layers. And we call those layers tunics of a vessel. Like an artery is going to have a really thick muscle tunic in the middle, where a vein is it's a little bigger maybe, but it has more of a thin muscle layer. So you can say, just by looking at this, you can tell this is an artery. This is a vein sometimes. So the innermost, and remember this hole right here, looking at a cross-section is called the lumen. That's where the blood flows, right? So it's got these walls. And if you remember from A&P1, the type of tissue that lines things like inside and out is epithelial tissue. So the tunica intima, sometimes you can call that interna too, is endothelium, simple squamous lining, right? And there's a layer below that, which is usually loose connective tissue like areolar. In an artery, or in a vein, not a capillary. Tunica media, I think this is the most important. This is where you have to live. And you just took an exam on vessels, so this is, you got to know what this means, right? How important this is. Because the sympathetic nervous system is going to be involved with the tunica media, which is all smooth muscle. Not cardiac. This is not in the heart. Sometimes we call that visceral muscle. And this is why. Because it also it makes up the walls of your gastrointestinal system, which you'll see later. We're talking about blood vessels, circular muscles, right? With the lumen in the middle and the big wall here of muscle. And the endothelium is just inside the lumen. So you could have vasoconstriction, which is narrowing the lumen. And most of the vasoconstriction, vaso means vessel, most of the vasoconstriction happens due to the sympathetic nervous system. Fight or flight, increase blood pressure. So contraction is going to increase blood pressure by increasing peripheral vascular resistance. So this happens in veins too. It does happen at the same time. So you should know that too. And if they relax, if you have sympathetic inhibition, then they're going to widen. And that's going to decrease blood pressure in arteries and veins. Now, arterioles and venules are a little bit more about blood flow when it comes to contraction around, or constriction and dilation. So the outer part is called tunica externa, or sometimes they call that adventitia. That's usually connective tissue anchoring the vessels to other tissue like muscles or bones even sometimes, or adipose. And they have some elasticity, and of course any connective tissue has collagen fibers. Collagen is the most abundant protein in your body because it's so abundant in all the connective tissue that's holding all this stuff together. So it's an anchoring to usually to muscles. So vasovasorum, vasorum, cool word, right? So vasovasorum has to supply the actual blood vessel tissue, oxygenated blood. So that's important, that you get blood to the epithelial tissue, the endothelium. So vasovasorum is actually supplying the blood vessels, the tissue in the blood vessels, the tunica media, the tunica interna, which is endothelial, and some of the tunica externa. So there's a network of little blood vessels that actually supply oxygenated blood and get rid of carbon dioxide through wastes for the blood vessels themselves. There's a classic, difference between an artery and a vein. So the biggest artery in the body is the aorta. And you know about the aorta. You know it comes off the left ventricle with the aortic semilunar outflow valve, checking the backflow going from the left ventricle to the aorta. But the aorta is very elastic. There's more elastic fibers in the aorta. So this is a typical distributing artery and vein, or distributing, I should say, artery, because the artery is serving oxygen to all the tissues in the body, starting off of the aorta. So these are branches off of the aorta. So let's look at some of the differences. Like both of the arteries and veins have endothelial layer, which is tunica intima or tunica interna. There's always a subendothelial layer in both of them. And there's internal elastic lamina and external elastic lamina, which is elastic fibers that seem to have some compliance and ability to stretch a bit. Now, both, and it looks like Swiss cheese, right? The elastic lamina. So it depends on where you're talking about. So the aorta has a lot of elastic lamina. The veins are kind of in between. There's not a lot of elastic lamina in there. The arteries maybe a little bit more. But here's the thing in the intima that's different in veins. Veins have valves in their lumens. Arteries do not. And it's not all veins that have valves, peripheral veins or systemic veins we're talking about. It's really the distal ones, like the ones that down in your lower leg, like the great saphenous vein, femoral vein, and then you have your common iliac veins. But in the vena cavas don't have valves, just the peripheral ones. So arteries don't need veins. Why do you think arteries don't need, arteries don't have valves? And why would you think they don't need them? I'll tell you why, because they're operating under so much heavier pressure. And they have this huge tunica media, which is the next layer out. Thick tunica media. It has its own vasomotor tone, which means it's kind of controlled by the sympathetic nervous system to maintain that tone. And of course, these blood vessels are getting their own vasovasorum to keep them contracting. So this is smooth muscle. You don't see a lot of that in veins, right? They have to rely on, well, I'll tell you what they have to rely on later, but they have to rely on valves to keep that blood moving in the correct direction, back to the right atrium, right? The arteries don't have to worry about that. They're just going to the tissue to deliver oxygen and other nutrients and fluids. The veins are returning the carbon dioxide back to the right atrium. And there's not a lot of pressure. There's a lot more pressure in an artery than there is in a vein, systemically, everywhere. Yeah, important, right? So the tunica externa is just connective tissue, right? Collagen fibers, areolar connective tissue that's going to anchor that vessel, both arteries and veins. So tunica media is really where we're going to live when it comes to blood pressures, especially in the arteries. Okay? So ultimately, the arterial blood is going to end up in the tissue capillary beds, right? We're not really talking about pulmonary right now. Let's just talk about systemic. And in the capillary, which is really just one layer of endothelium, there's no tunica media in this. They have some connections external, but this is a network. This is like, all of this is like waterfalls and moving streams, but this is now you get into that bottom pond where things have to slow down and be exchanged under lower pressure. Nice wide pond. So there's many capillaries in one capillary bed, which kind of shows it here. And you can see the red blood coming in oxygenated, then it's mixing with purple in the capillary beds, and then leaves deoxygenated, so less oxygenated. So let's get something straight. Let's talk about this for a minute. Now that you know the histology, basically, of an artery and a vein. When I'm talking about oxygenated blood, how many, first of all, let's be clear. What molecule inside the red blood cell carries oxygen? Probably talked about this already.
Hemoglobin.
Hemoglobin. So hemoglobin, and there's about 250 million molecules of hemoglobin in one red blood cell. So hemoglobin can carry 4 molecules of oxygen gas, O2. So in an artery coming from the left ventricle, which you should know, had just recently come back from the lungs. So it's fully oxygenated, 100% oxygenation, right? 100% oxygenation when it leaves the left ventricle. So the aorta, with all its branches going to the brain, to the arms, to the torso, to the legs, to the genitourinary area, gastrointestinal, all delivering oxygenated blood under pretty good pressure because of all this tunica media. So once it goes into the capillaries, the blood, the oxygenated blood, that's where the exchange is going to happen. Oxygen into the cells, which has to get into the mitochondria to make all that ATP, right, through aerobic respiration. And what's the byproduct of that? It's carbon dioxide. Well, our body doesn't like carbon dioxide. That's got to get the hell out. So carbon dioxide diffuses into the veins, of course, or into the capillaries, and goes up into the venous system back to the right atrium. And that hemoglobin, again, hemoglobin has 4 binding sites, but there's 3 of them bound with oxygen gas. So technically, deoxygenated blood is 75% oxygenated, meaning that 3 of the 4 hemoglobin binding sites are occupied. So we can't live like that in the arteries. If we have 75% oxygen saturation on hemoglobin in the arteries, we're in big trouble. We're going to the ICU. We're turning blue. But in the veins, that's completely appropriate because it's on the way out, under low pressure. So let me ask you this. Knowing what you know from lecture and what I'm telling you about tunica medias and valves and elastic lamina and pressures, how does the blood in the systemic veins get back to the right atrium in a timely fashion, enough to get good cardiac output eventually? Same as the left atrium, but the deoxygenated blood, you know, is going to the right atrium from the vena cavas and the coronary sinus. So how do we get blood back to our hearts in a timely fashion where it's not going to just stay in the periphery and cause edema or something like that? Anybody know? This is a really important question. What do we have to do to keep blood moving forward, anterograde, back to the right atrium?
It's body movement, right?
Yeah, skeletal muscle contraction. It's a skeletal muscle pump because the deep veins need that skeletal muscle pump, moving your legs, walking, exercising, of course, and that's called venous return. That's one of the ways. Very good. What's another way? Think of what's in veins that aren't in arteries in the endothelial layer. Veins have what?
You have the valves.
They got the valves. That's right. And what's the function of a valve? To prevent what?
It prevents backflow.
Prevents backflow, retrograde flow. Because if that's not going back to the right atrium, it's staying in the periphery, especially in the legs. And you're going to have what's called edema if that blood doesn't get back. So the valves are another way that increases your venous return to the right atrium. And also your breathing, your diaphragmatic breathing, your diaphragm elevating up and down. And it causes like a vacuum too. When your lungs expand and contract, it causes a vacuum in the vena cavas. So diaphragmatic movement, respiratory function, skeletal muscle pump, and valves increase your venous return. So you can have the blood going back to the right atrium pretty much the same time it's going to the left atrium. So you can have good ventricular filling ultimately. You know this stuff. Did that in lecture. So companion vessels, got to be careful with this though, when you're naming them, because I'll tell you right now, the one that's most confusing is probably the carotid. Like the carotid is just an artery. There's no carotid vein. Jugular vein is just a vein. It's not an artery. There's no jugular artery. Saphenous is just a vein. It's not, you're not going to have a companion vessel, but most of them are. And you know that weird, you know, like when the aorta comes out of the left ventricle, you have the aortic arch, and then you got the brachiocephalic trunk, and then you have the left common carotid artery, and then you have your left subclavian artery. So that's kind of a strange setup. So you have to know, you know, if you're looking at the heart, and here's the left ventricle, right? This is coming from the left ventricle with the aortic semilunar outflow valve. You have the 2 coronary vessels right above the aortic semilunar outflow valve, which is feeding the heart, right? Left and right coronary artery. It's actually off of the ascending aorta. And then you're going to have branching with the brachiocephalic trunk, which is of course going to branch into the right common carotid artery and the right vertebral artery. And then it's going to go down to your right subclavian artery. So this is going to branch. So that's a little bit of a asymmetry. And the left common carotid is going to branch to the internal and external carotid arteries. And then you'll see what happens with the subclavian when you go into the armpit where the humerus is, right? And it goes through there. It's called axillary. And now they pretty much can be compared. Like you could have your right subclavian artery, left subclavian artery and your left subclavian vein. And then you over here, you have your right subclavian artery and your right subclavian vein coming the opposite direction, going back to the heart towards the vena cava. So these are all arteries I drew here. So yeah, like the radial artery, radial vein, brachial artery, brachial vein. There's a vein called cephalic vein, which doesn't have a companion artery. So just listen to those and that'll help you. But most of them are paired, like femoral artery, femoral vein, common iliac, right and left common iliac arteries, right and left common iliac vein, brachiocephalic veins. So that's what that means, companion vessels. And you know about all this. You know the thicker tunica media, because these arteries are serving oxygen. They're distributing arteries. And they're muscular. The aorta is muscular too, but the aorta is more elastic. Like this is very elastic, a lot of elastic tissue in the aorta. And then it goes down behind the heart, right? It comes out here, and then you have the diaphragm. So the descending aorta comes down behind the heart, between the heart and the thoracic cavity, or thoracic spinal column, I should say, through the mediastinum. Okay, so it's more elastic, especially the aorta. So it's more resilient because it's operating on higher pressure. This left ventricle, again, I tell you, this left ventricle is not, again, this is not Kanye West. This is Jimi Hendrix. That's the rock star of the heart, pumping heavy pressure into the aorta. And the aorta has pressure of its own from all the distributing arteries that are behind it. That's important. You probably learned that in lecture, right? The left ventricle, the pressure in the left ventricle has to overcome the aortic pressure in order to open that valve and eject blood into the aorta. Crazy stuff. So veins, thicker tunica externa, right? Because they're anchored deep into the muscle, especially the deep veins. Superficial veins, not so much. And they usually have larger lumens, like I drew before, because the arteries are smaller, kind of tight lumens, you know, with the tunica medias, where the vein is usually kind of oblong like this, and the lumen is bigger. That's what that means. And veins have valves, and they're a bit less elastic. But they do have tunica medias, it's just a lot smaller. So an empty vessel, of course, dehydration, or it could be a connective tissue issue, the walls are going to collapse a lot easier because they don't have pressure supporting them. They don't have pressure. They don't have the left ventricle. The veins are coming out of the capillary beds. No pressure, zero pressure, actually. So that's why venous return is so important. That's why I made such a big deal out of it. So the capillaries, tunica media only, right? Just endothelium and the basement membrane. Simple squamous, right? Good for diffusion, you know, these kind of cells with just that one basement membrane on both sides. And this is what the endothelium looks like in all vessels, but in capillaries, there's no tissue around them, just enough to support it. So of course, this is for diffusion, gas exchange, CO2, get that stuff out, and O2 in. Nutrient, like your amino acids, your glucose, fatty acids, and other things, of course, fluid and hormones, really important, thin walled. So capillaries is where the magic really happens. So the vessels, the bigger vessels, the arteries and veins are basically just roadways from the heart and back to the heart. And you know all this stuff. Here's the brachiocephalic trunk. Here's the left common carotid. Here's artery. And here's your left subclavian artery. So now be careful when you're taking an exam. You make sure you say artery and vein at the end of your answer in the fill-in part, especially the carotid. And unless the question asks just for an artery, you can just say that. But you should put artery and vein because they are companions. There's a lot of arteries and veins that have the same first name. So yeah, be careful. So the ascending aorta, and here's the descending aorta down here. So basically the brachiocephalic trunk is going to feed the head through the carotid artery and vertebral artery and then go down the arm. And it has other branches to the face and whatnot. The left common carotid is going to feed the left side of the face, oxygenated blood. And the subclavian is going to feed the left arm. And there's a branch called vertebral artery that also goes up into the brain. Okay, so this is a nice picture showing you the difference in the layers. And don't forget the aorta is very elastic compared to the distributing arteries. These are distributing arteries down here. So the aorta is very elastic. And you've seen the connective tissue, the elastic connective tissue that's in the aorta last semester. So there's a lot of elastic lamina in here because it's operating under so much pressure from the left ventricle. Jimi Hendrix. And the muscular arteries are distributing arteries. They're sending the blood into all the tissues of the body, even the brain, right? The brain is up here, right? So these common carotids and vertebral arteries are feeding the brain. And there's a bottom of the brain network of vessels called the circle of Willis, which involves the internal carotid and the vertebral artery. So the arterioles now, here's an arteriole. So it has all the other goodies. It has an intima, it has a media, and it has an externa, but it's not as muscular, right? It starts to narrow down a little bit because they're smaller branches. You know, like these big vessels, the aorta is like Route 95, you know, major artery, and the muscular arteries are more like the branches, 287 and all the parkways. And the arterioles are the roadways going to each individual block. And the capillaries are home, baby. They're home in the capillaries because that's where everything is exchanged. That's where we come home. And then on the way out, you have the venules, which have all the goody layers, intima, media, and externa. And then they get a little bit bigger as they're going back towards the vena cavas, right? And there's larger veins too. So vena cavas do not have valves, though. You should know that. So really everything from the bottom of the diaphragm comes back via the vena cava, inferior vena cava. And everything from above, the upper trunk and the head and neck and arms come into the superior vena cava. And don't forget, all the blood from the heart muscle itself enters the right atrium from the coronary sinus, which is a vein. Coronary vessels, please don't forget those. I like to talk about coronary vessels, which you probably did in lecture. So this is a roadway to go home. The heart is just a pump. I mean, I don't mean to belittle the heart or anything, but that's just a pump. A magical pump, automaticity, all those pacemakers and everything, but basically it's just a pump in roadways to get the oxygen to where it needs to go, especially the brain, because the brain controls everything. Yeah, so the lumen, of course, is decreasing as you get off 287, right? And of course, the elastic fibers will decrease as you get deeper because you want more muscular tissue when you're going towards the houses, right? In the arterioles and capillaries. So the relative amount of smooth muscle increases. That's kind of important because when you get to arterioles, now we're really going to control blood pressure and blood flow, right? If you have sphincter muscles that kind of allow a certain amount of blood to go into a certain tissue, then those muscles become really important in places like the arterioles, right outside of the capillary beds. Crazy. So you have your arteries, you have your elastic arteries, which is really the aorta, Route 95, right? Operating under high pressure from Jimi Hendrix, the left ventricle, right? They have muscle, they have a tunica media, but they have more elastic lamina. Your muscular arteries are very dense in the inner wall of the tunica media, smooth muscle, controlled a lot by the sympathetic nervous system. Arterioles, a little bit less muscle, but they still have it, and they have more control with valves and sphincter muscles that kind of allow a certain amount of, when I say valve, I'm talking more like a valve that you use to turn a water spigot on, you know, where you let the water flow out. Like say you had a spigot, right? And you put like an adapter that has like 4 different hoses on it, and each hose has its own valve. You could direct the blood flow to one side of your garden one day and stop at another, or have 2 different flows going at one time. So your autonomic nervous system, especially sympathetic, controls how much blood flow you get into certain tissues, right? Does that sound confusing? Are you with me on this? let's look at it this way, right? Let's look at it this way. Say, you know, what are we eating today, by the way? We'll have a burrito. Let's have a breakfast burrito right here in Central Park, right? I'm sitting down, eating my burrito, and the blood is flowing to my digestive system. My sympathetic nervous system is not activated. I'm under parasympathetic, which relaxes those blood vessel tunica medias, not directly, but it kind of inhibits the sympathetic nervous system. So I'm able to get blood flow to my esophagus, of course, my stomach, my small intestine, my large intestine, my colon, the whole bit, pancreas for exocrine function. But then all of a sudden a coyote comes after me. Now everything's going to go into sympathetic, fight or flight, right? Parasympathetic was rest and digest. So now I'm in fight or flight. So now the blood is going to be shunted to either definitely my brain. So I could decide whether I'm going to fight this coyote off or I'm going to run away. So then there's also blood shunted to my skeletal muscles to run away. I make that decision. So the arterioles control that blood flow based on sympathetic input. Sympathetic, adrenergic, norepinephrine. You remember that, right? Norepinephrine is fight or flight. Speeds things up like heart rate. And it squeezes and vasoconstricts your muscular arteries. Vasoconstriction. Let's just talk about that now because this is a big topic. Vasoconstriction of arteries and veins too will increase your blood pressure because it's increasing your peripheral vascular resistance of flow, right? So one of the main causes of increasing peripheral vascular resistance is narrowing the lumen of the vessel. And it's if you narrow it by half, that's like 16 times more pressure. So if you narrow it a little bit, and you narrow it by contracting smooth muscles, causing vasoconstriction. And if they relax, you'll get vasodilation. That'll decrease your blood pressure by decreasing your peripheral vascular resistance. Crazy stuff. So these are the conducting arteries, the elastic. They call them conducting arteries. Don't be confused with the nervous system. So this is the Route 95, the large vessels, the large roadways, right? And they're conducting the blood to the distributing arteries, which are muscular arteries. So the elastic arteries, of course, have a lot of elastic CT. So they could comply and they could stretch and comply and recoil back to their original shape and original lumen size. Yeah, very important. So this helps propel blood through the arteries during diastole. I can't skip over that because this is a really important point. So an example of the conducting arteries are the great vessels. The aorta, which of course is the most elastic. Pulmonary trunk is a big one, but doesn't really need that much elasticity. Common carotid, that's pumping blood to your brain. That's got to be really have a good amount of elastic lamina coming off of that left ventricle. Common iliac arteries are pretty much where they start to branch below the diaphragm, where the aorta branches below the diaphragm. And that's where you have to learn for this class. You have to learn what the branches are. So first of all, diastole and systole. Are we clear with what that means? Which one is contraction of the left ventricle, systole or diastole? I don't want to take this for granted. Which means contraction, systole or diastole?
Systole.
Yeah, systole is contraction, right? So that is when the left ventricle and the right ventricle, but let's face it, it's more about the left ventricle when it comes to arteries. So the left ventricle is contracting, the valve is going to open, aortic semilunar outflow valve, and you're going to push blood with high pressure into the aorta and then to all the distributing arteries. And you know what cardiac output is, right? Right? Everybody knows what cardiac output is. You just took a test, you told me. So cardiac output is the stroke volume, right? What comes out of the left ventricle times your heart rate. So heart rate is very important, of course, to get cardiac output. And of course, stroke volume is even more important. How much blood comes out of the left ventricle into the aorta per minute? So if you have 5 liters of blood, which is like 5 pints, right? Around there, if you have 5 liters of blood and your heart rate is 75 beats per minute, you're pumping 5 liters per minute out of that left ventricle into the aorta at a very high pressure, right? So the aorta and all the muscular arteries have their own pressure. So now what happens in diastole, right? Diastole is when the aortic semilunar valve is closed and the ventricles are filling. So that's diastole, when the heart muscle, left ventricle especially, is in a state of relaxation, right? It's depolarizing, but it's not contracting. So the arteries have that period of diastole, which is a little bit longer than systole, because it takes a little bit more time for the ventricles to fill, to get that end diastolic volume, right? And the end stroke volume is the end diastolic volume minus the end systolic volume. So, which you just had a test on, so I don't want to keep talking about it. But what's really important is that the arteries, starting at the aorta, have their own pressure, even in diastole, which is really important. And that's the vasomotor tone due to that contraction of the smooth muscle, that tone. And it's controlled by the sympathetic nervous system in a good way. I'm not talking about coyotes coming after you, but you need sympathetic tone all the time to maintain your peripheral pressure in your distributing arteries in your aorta. Really important. Now, what would happen if the aortic pressure was too high? Think about this. Say your aortic pressure is too high because you have hypertension, right? The average blood pressure in America is what? 120 systolic over 80 diastolic. So what if your blood pressure is 190 systolic over 100 diastolic? That's your peripheral pressure. That's the pressure I took in your distributing vessel in your arm, your brachial artery, say. So that means that you have high peripheral vascular resistance because for whatever reason, maybe you ate at Popeyes too much. Maybe it's genetic. Maybe you're under a lot of stress, so your blood pressure goes very high. But you got to understand that the left ventricle has to overcome that peripheral pressure in the arteries and aorta. And every time it pumps 75 times per minute, say, it's going to have to fight against that. So if the stroke volume goes down, right, say the stroke volume goes down, what has to go up? Can anybody answer that? That's a really important question. If my stroke volume, my heart goes down, what has to go up to maintain that good cardiac output, to get the oxygenated blood to my brain and other tissues?
The heart rate.
The heart rate. That's right. The heart rate has to go up, and that's completely appropriate, but it's going to cause a problem. What's it called when your heart rate goes above 100 beats per minute at rest? Is it tachycardia or bradycardia? Tachycardia. So a sick heart is going to go into tachycardia because that's all the sympathetic nervous system cares about doing, is getting good cardiac output to get that oxygenated blood to your brain. So during diastole, the arteries, distributing arteries, maintain that vasomotor tone, and they have their own pressure. So that's why diastole is important. And that's why you take the diastolic blood pressure as well, which should be maintained at, below 89, right? Diastolic blood pressure, systemic blood pressure, which we'll talk about later. Okay. So the distributing arteries, again, these are the other ones. These are more muscular, and they go to all tissue and all organs. So you'll learn like the renal artery, the hepatic artery, the mesenteric artery, the gonadal artery, all branches of the aorta arteries we're talking about going to from the heart. So I have a checklist. It's not really that long, so it's not too bad for 2 weeks. It just needs a little repetition, a lot of repetition. Okay, so this is where a lot of that vasoconstriction, narrowing the lumen, and dilation, increasing the size of the lumen's radius. So vasoconstriction is decreasing the lumen, increasing blood pressure. Dilation is increasing the lumen size, radius, and decreasing blood pressure. Right, and it doesn't happen like it does. It's not like it constricts every systolic beat and then goes through dilation every diastolic. It doesn't work like that. It has its own regular tone. And here's the elastic lamina. It has that, even though not as much as the conducting arteries like the aorta. So here's the names, and these will be companioned or paired. I like the way your book says companioned. Sounds so nice. And then the coronary arteries are a little bit different, though. It's just have left and right coronary artery, basically. Then they change. So you should know the coronary arteries by now from lab, and now we'll learn the other ones, the other branches. Arterioles are the smallest, of course, going towards the capillary beds, 0.3 to 10 micrometers, depends on what part of the body you're talking about. And they have the 3 tunics, generally. Some of the smaller ones closer to the capillary beds don't have. They're more like a capillary, but they still have muscle, and it's a single layer of smooth muscle. So they all have a layer of muscle, every one of the arterioles. And they're really important in maintaining this vasomotor tone throughout the whole arterial system. Venous, not so much, right? Low pressure in the veins. I mean, listen to you have to calculate like mean arterial pressure, right? You do that pulse pressure. So you saw that it's much higher in the arteries than it is in the veins. And where's the vasomotor center? What part of the brainstem? Let's get this straight now. It's the cardiovascular center too. This is the medulla oblongata. If you remember, the brainstem has the midbrain, pons, and the medulla oblongata. So your cardiovascular centers and your vasomotor center are in your medulla oblongata. So it could be inhibitory, decreasing constriction, or excitatory, which increases constriction of blood vessels. Heart rate, same thing. That's cardiovascular center. So vasomotor is about blood vessels. Vaso usually means vessel, blood vessel. So systemic blood pressure, that's that 120/80, right? 120/80 blood pressure, systolic and diastolic. And the arterioles also, like I told you before, when I'm eating my burrito in Central Park, the blood flow to certain areas, sometimes to my lungs, sometimes to my brain, sometimes to my skeletal muscle, sometimes to my stomach. So arterioles have those precapillary sphincters, those circular muscles that act as valves. And not the valves that prevent backflow totally, but different types of, more like spigots. I like that better. So here's the histology. And this is a classic aorta, right? Elastic. And the common carotids too, especially the left common carotid, which is going to branch even further. So you can see more elastic lamina. That's really the difference. It has a tunica media, and here's the lumen up here. It has an endothelial layer, which is really important. And then here's a muscular artery, which relies more on the tunica media. And the extern is here, really. This is all other connective tissue in here. But again, a tunica intima, which is endothelial cells. Arteriole generally lacks the smooth muscle, but it has one layer of smooth muscle in most of the arterioles. Same thing, tunica intima, tunica media, and then your tunica externa. And this is the capillary, and this is, I just put in continuous capillary here, I believe. For lecture, you probably had to know what a sinusoid was and a fenestrated capillary, but we're going to talk mostly about the continuous capillaries, like the ones that are in the capillary beds and tissue. Because a fenestrated means windowed, like has window, and that's more in the kidney for filtration and reabsorption. In the liver, you have what's called sinusoids, which are very large pores between the capillaries. So this is kind of in between. So most of our capillaries are continuous capillaries, like the one I showed you before. And there's clefts in between the endothelial cells, makes them slightly porous, and they are porous, because this is where you want your fluid exchange and, of course, the gas exchange. So the larger particles, like you don't want red blood cells and proteins leaving your blood vessels. That's really important. They have to stay in. There's a protein called albumin, which maintains your osmotic pressure in your capillary beds, fluid beds. So you don't want proteins leaving. Because if that happens, you're going to get your whole osmotic pressure is going to get thrown off, and you're going to wind up having an edema and other medical problems that can lead to heart failure, actually. And you don't want red blood cells leaving the vessel. They never leave the vessel unless you're cut, unless there's so massive permeability due to histamine release or something like that. So that's not normal inflammatory response. So proteins and cells, especially red blood cells, stay in the vessel. So capillaries is about just big enough, 7 micrometers, whatever size that lumen is, to house a red blood cell. And of course, you have a lot in muscles because muscles need all that vascularity, and skin and lungs. You can go on. I mean, these capillaries are in every tissue, especially the CNS, right? The brain, because you need oxygen to get to those neurons, because the neurons of your brain control everything in your body in one way or another. Brainstem, cerebrum, diencephalon. So here's a classic capillary bed. And you can see those cuffs of smooth muscle cells that kind of control the flow of blood and by constricting the lumen if it needs to. Right? So the venous end of the capillary bed, which are venules, right? These are arterioles. These are venules. And sometimes they call them metarterioles, or like a T joint, right? A T joint with a capillary, the arteriole is going to have other T joints to other capillary beds. So that's a metarteriole. And then the other side, so blood flows in one direction, anterograde, right? From the arteries into the capillaries, then out to the veins. And you have these precapillary sphincter muscles, which are smooth muscles that are controlled sometimes by themselves. Like they have, again, you're going to do endocrine, right? Endocrine you did last semester. So some of these cells could actually control their own based on what they need. So they might not need 100% sympathetic stimulation. They could release their own vasoconstricting and vasodilating chemicals. Like you may have heard of prostaglandins or bradykinins, histamine, things that change the diameter of the blood vessels locally. So they have their own autoregulation, some of these, based on need, especially oxygen. Think about that in the heart when your blood vessels need to dilate to get blood flow to an area of the heart that's injured. So now if these are contracted, you're going to have less blood flow into the capillary system. So it starts out here with the sympathetic nervous system and then has its own autoregulation within. So if we don't need if we don't need oxygen or other fluids or glucose in this tissue bed, it's going to bypass it and just go back into the circulation in that particular tissue bed. Tissue capillary bed is a better way to say it. So veins, okay, now this is systemic veins, of course. Pulmonary veins are basically the same, except the histology is different. So these are more the systemic circuit, the blood coming back from the tissue capillary beds. So venules are the smallest, the cute little ones, right? And they companion up with arterioles. You don't have to name all the arterioles, you have to name the arteries, the distributing arteries later. And the smallest venules are post-capillary venules. And the largest one have 3 tunics, and the larger one. So there's difference in size going from the capillary beds. And they ultimately will drain blood, deoxygenated blood with only 75% hemoglobin saturation of oxygen. And the veins will go to the vena cavas and then to the right atrium. And off it goes into the pulmonary circuit via the pulmonary semilunar outflow valve, into the pulmonary trunk, into the pulmonary arteries, and then into the alveolar capillaries where they're going to pick up more oxygen and bind it to hemoglobin. The veins, again, small, medium, and large. This is very variable veins. Veins are, they operate under low pressure. And you should know one thing, which you probably do from lecture, that probably like 65 to 68% of the blood in your body at one time is in the veins. So the veins are kind of like a reservoir of blood. Blood kind of hangs out there a little bit longer, and it is ready to be used. Like say if the coyote is chasing me, through Central Park, then I could get some blood from my veins as well as my arteries to my tissue. So the venous blood will go back faster, venous return. So that even they do have that tunica media enough to constrict, to increase blood pressure and increase venous return. Yeah. So the larger ones are companioned, right? And like the vena cavas travel with the aorta, basically. Like the abdominal aorta is paired basically with the inferior vena cava. And up on top, the brachiocephalics are kind of paired with the brachiocephalic veins, and then the superior vena cava. So this is more about below the diaphragm. And they have valves. Most veins, not all, have valves that prevent backflow, right? So it doesn't pool. Because if you have blood pooling in the limbs, the lymph system, and the function of the lymph system is to reabsorb any excess fluid, and it can't handle this. So you're going to wind up, if your blood is pooling due to poor venous return or blood clot, a thrombosis, you're going to have, or heart failure even, you're going to have what's called edema. And this will increase your blood pressure very quickly. So edema is excess fluid in the tissue. So the valves in the veins are made up of basically your endothelial cells and some elastic and collagen fibers, pretty specialized structures. Just like in the heart, except the heart of semilunar valves or have a lot of more connective tissue than they do endothelium, but they have both. So the veins are kind of like a blood reservoir. So at any one time, at rest, of course, you're going to have, like I said, like 68, even 70% of the blood is in the heart, is in the veins, the systemic veins at one time, especially systemic veins. Yeah. So at rest. So that's 55, it says, I'm sorry, 55%. So it could be around 60. And 18% in the pulmonary circulation, 12% in the heart. These seem to change from book to book. And systemic circulation, 70%. So most of that is in the arteries, in the veins. And it's probably because it's such low pressure. So you don't have to know those numbers. Just know that the veins is the reservoir for blood. That's where most of the blood in your body is at one time at rest. At rest. All of this is basically at rest, even when you do blood pressures, unless you're doing cardiac stress testing, exercise stress testing. The blood is basically in your veins mostly at one time. So vasoconstriction could happen in the veins as well. When you need more blood during exercise, of course, sympathetic, because exercise is a great sympathetic response. Or when you need venous return, right, at rest. Anastomosis is like a combination of a connection between vessels, and it can happen with arteries, especially in the intestinal area. Anastomosis is what gives you what's called collateral circulation. Especially when you have all those folds of digestive tubes, there's a huge anastomosis where the arteries kind of blend together and form connections. So collateral circulation usually is very important when there's blockage of flow, that you have collateral circulation, especially in the heart. Venous anastomosis are more common, right? It's between the actual systemic veins, like basilic, you learn all these, cephalic and upper limb. Sometimes you have a shunt or a portal system, which you'll see, an arteriovenous anastomosis, where they're kind of working together, like the dorsalis pedis and different areas of your extremities and parts of your ears, and also around your brain too. You'll have the arteriovenous anastomosis. So anastomosis is like a connection between the vessels. Maybe there'll be a good picture coming up. So a portal system is, we're going to do mostly with the liver, hepatic portal system, because the liver deals with a lot of digestive blood flow. So like when you're absorbing your nutrients in your intestines, it goes to the liver first before it goes back to the vena cava. because the liver has to manufacture proteins and manufactures hormones and bile. It's a big manufacturing zone, the liver. So the liver has a portal system. The pituitary gland also has a portal system. So you have the arteries going into the capillary bed, and then the portal vein will bring it back to a place like the liver. And then the liver will bring the oxygenated blood back to the vena cavas. And you'll see that. Like this is the one that's by the pituitary gland, hypothalamus. Hypophyseal is the pituitary gland. That means pituitary gland. Because you're dealing with a lot of hormones going back and forth from the really one direction, mostly from the hypothalamus to the pituitary gland. And that's a portal system, a system within a system. So those two would probably mean the hepatic and the hypophyseal portal system. Okay, I think we got to take a break. You guys are getting a little too long here. So here's some of them, and you can go through your checklist for the arteries on the ones that are important to know. But let's just go through these today before you do your lab, just to get a good idea. So coming out of the heart, of course, you have the aorta, and then you have your brachiocephalic, and you have your left common carotid artery and your left subclavian artery. And then as the arteries go from subclavian to the underarm, the mid-axillary line, it's called axillary artery, which makes sense, right? That's how, remember, they're paired from here on out. They're all going to be paired, except for, of course, the aorta. Right and left is what I mean. So you have to say that if you can, if you're asked on the test to say right or left. And there's an internal thoracic artery, which is not off of the subclavian. And brachial artery now is the next one in the upper arm. And this is the one we're going to use to put the cuff on to take blood pressure, either palpatory blood pressure or auscultatory. Auscultatory means to use a stethoscope to hear the beats. Okay, and there's a deep brachial artery. Now this is where it gets a little different in veins. Like there is a brachial vein, but there's also a cephalic vein and a basilic vein, which kind of gets confusing there. So that's not completely companioned, as I like to say. Right? So going upward, remember you have the brachiocephalic trunk, which is going to branch to the right subclavian and the right common carotid. So that's off of the brachiocephalic trunk. And there's a vertebral in there. It's not shown on this picture. It's like pretty much comes off right here, which you'll see. And the left common carotid artery will branch to internal carotid artery and external. So I'm sure that's what we need to know there. And the aorta is ascending to the aortic arch, and then it'll start descending. So it's posterior to the heart, in front of the thoracic vertebrae. And then, like it doesn't really show you here, but really you have your diaphragm, right? Your diaphragm kind of separates. So below the diaphragm, we could start with what's called the abdominal aorta. Above the diaphragm, then I'm talking about descending. Above the diaphragm, you can call it the thoracic aorta. Still aorta, and still descending aorta. But just to break it down from the abdominal cavity below the diaphragm. And the first branch below is the celiac trunk. It's a big trunk because it has multiple branches. Like it has the hepatic artery, which goes to the liver, the pancreatic artery and the splenic artery going to the pancreas and the spleen, and the gastric artery. So you have to go a little deeper into those. And by next week, we'll get all of those down on the checklist. And there's a superior and inferior mesenteric artery. These are a little tough to see. They are not paired, actually. It's only superior and inferior. So see where the superior mesenteric artery starts below the celiac trunk, and the inferior is way down here. So in between, you have the gonadal arteries, and you're going to have paired veins there too, and mesenteric as well. Then the artery that goes to the kidney, and it doesn't show the kidney, but the kidney would be here. And the renal artery goes to the kidneys. So that's important. The gonadals are lower. So in the female, they're going to the ovaries. and to the male, it's going to the testes. And this is very similar to the veins where you have like this bifurcation here. And you have the right common iliac artery and your left common iliac artery. Then they branch to internal iliac, right and left artery. And then this will be the external iliac artery. And then as you go down, makes sense. And they're completely paired with veins. Companioned, as your book says. I like that. So the femoral artery goes to the anterior thigh here. And it's feeding both anterior and posterior tissue. So your femoral artery, which has a branch called the deep femoral artery. And then here you have your popliteal is behind the knee, right? Popliteal artery, posterior knee. Then you have your posterior tibial. Let's see if we can see a good posterior tibial because this is behind. It's in the back, right? Feeding the gastrocnemius posterior tibial. And then anterior tibial, more tibialis anterior. And this would be your dorsalis pedis. So those branches, do the checklist. This is the diaphragm, which I showed you. It could be called abdominal aorta. And you see the bifurcation to right and left common iliac artery. So make sure you say artery because that's what we're doing. But later on, there's going to be some veins. So the veins kind of go along that route. Let's just look at those real quick before we go back to blood pressure. And now you don't have carotids. Now you have jugular veins. So remember, this is coming back. So by the end of the next week, you should be able to trace blood, like say from the toe back to the brain, even through the heart. So dorsal venous arch is the anastomosis of veins down on the top of the foot, the dorsum of the foot. And then you have your anterior and posterior tibial veins, popliteal veins. Now here's one that is not an artery. There's no companion to the great saphenous vein. It's a long vein, medial vein. And it comes down, sometimes they call this the small saphenous vein down here. In fact, this is so big that they use this for grafting. Like if they're going to do a coronary bypass, they would actually take your great saphenous vein, sew it back together, and then take the great saphenous vein that they grafted and connect the aorta to the myocardium to bypass a clogged coronary artery. And now you got a nice companion femoral vein, deep femoral vein, and you have the internal and external iliac veins, common iliac. But now, and there's a gonadal veins, they're all companioned. And then you don't have aorta, of course. Now you have the inferior vena cava draining blood right all the way back, all the way through. You don't have to say abdominal or thoracic region of that, of course. So that's the vena cava is going, inferior vena cava is going back to the right atrium. Then you have, again, you're going to see this, you have the palmar venous arches, that's venous anastomosis. And radial vein and artery, too, is on the thumb side in the anatomical position because he is in the anatomical position. And you have the ulnar, which are more medial towards the pinky, towards the fifth digit. So in here would be the ulnar veins draining back. Here's the median cubital vein, right? And that's probably where you could take some blood from the venous. Of course, when you draw blood from somebody, unless you're looking for blood gases, you're going to draw it from a vein because you don't get squirted, right? It's not operating under high pressure. This is one that's cephalic vein is a big one because that's the more lateral vein that's not paired with an artery, so I have to star that one. You have brachial and basilic veins as well, and you can take blood from those as well. And that's easier. You can take blood from any vein if you could pinch it, right? And then you have the axillary. Now it gets a little weird up in here, like the brachiocephalic, like the right brachiocephalic is a very short distance, draining the subclavian and the jugulars into the superior vena cava, which goes into the right atrium. So up here, this only goes as high as the left external and internal jugular. Now jugular is not a companion because it's carotid in arteries. This is veins. And then you have, of course, left subclavian vein is coming from the arm. And these are all the arm. and hand veins draining back to the, ultimately, to the left brachiocephalic on the left side. And that's just this part right here. And then into the vena cava, superior vena cava. So that's a good look at all the different veins and arteries and which ones are companion and which ones aren't. It's really not that much, really. Okay, let's go back to where we were, measuring blood pressure and pulse. I kind of mentioned the lymphatic system too as well. Here's where I was before, showing you pictures. I don't know to recap how far back I was, but there was a really good picture in here somewhere. Edema, just showing you what I was talking about with the blood being the veins being the reservoir for blood. Because in any one time, that's where the blood is, mostly in the veins. Anastomosis, connection, and the portal system. It's a circulatory system within the circulatory system, especially the liver, which is the hepatic portal system, and the hypophyseal between the hypothalamus and the pituitary gland. Very big endocrine portal system. So this is talking, I'm not going to go into any of the laws that you might have done, fixed law, and that you did in lecture. But of course, what affects blood flow and pressure is really important. So of course, the diameter, I think, is the most important. The diameter. So that's the most important in pressure and blood flow, the diameter. But there's also the length of the vessel is important. Like somebody who's obese, their blood pressure is normally going to be higher because they have longer vessels, right? So that affects the blood flow velocity, the speed of blood flow, and increases the peripheral vascular resistance. And the other thing, besides the diameter, radius, and the length of the vessel, is the blood, like the viscosity of blood itself. Like if you have too many red blood cells, it's called polycythemia, which is like the opposite of anemia. Anemia is too little of blood cells or iron. So excess blood cells can cause increase in blood pressure because it increases peripheral vascular resistance. But cross-sectional area is the one you should know the most when blood pressure is changing. This is a really good look at the way the arteries and veins change in pressures, right? And arterioles and capillaries. So the total cross-sectional area, the way it changes from the elastic arteries to the muscular arteries to the arterioles and in the capillaries. But things slow down a lot, right? It slows down a lot. So the cross-sectional area of the capillaries in total, you got to picture that a big pond because there's so many of them. That's really the point. It's not the size of the lumen, it's the cross-sectional area of the surface area of all the capillaries together have this very large surface area. So the total cubic or centimeters squared are a lot bigger. So it slows down, really. The velocity slows down in the capillaries. That's the whole idea. And it's harder to get blood back to the veins because you're operating at lower pressure. So the velocity is as high because you have venous return. But up here, it's massive because of the left ventricle. So I kind of like that superimposition of those two, cross-sectional area and the velocity. Makes sense. I mentioned the lymph system because this picks up the 15% of the fluid that's not reabsorbed. So 85% of the fluid in the tissues, interstitial tissues, is returned to the capillary, but 15% of that is put back in the lymph system. So if you have a problem with your lymph system or you have a problem with proteins leaking out, you're going to have what's called edema if there's too much fluid in the interstitial area. And that could be due to heart failure as well. So this, I kind of mentioned this before too, like how much blood you have in those areas, like skeletal muscle and brain, of course, have high blood flow, and heart, myocardium, and liver with the portal system. And this is what I was kind of talking about before with angiogenesis, is smooth muscle, really. Smooth muscle and endothelial cells can undergo mitosis. So those smaller capillaries can regenerate themselves and add more to collateral circulation. That's growth. That's actually new growth of blood vessels. It, of course, doesn't happen in the aorta or the coronary vessels, of course. But it happens in the capillaries in the heart. Like if you have a blocked coronary vessel, especially as you get older, you'll develop collateral circulation. And that helps get oxygen to the myocardium on demand, really. I mean, you still have the coronary vessel that's blocked, though. So this is, did you ever hear of, let me get in your face for a minute. This is an interesting topic. Did you ever hear of the widowmaker? You know, when somebody has a heart attack, like in a young age, like really young, like 30, even early 40s, you know? So they call it that because like an older guy, like me, you know, as you get older, you develop collateral circulation, especially if you have some type of ischemia, decrease in blood flow in the coronary vessel. So that develops over time. And you might, of course, have chest pain like angina. But somebody who's young doesn't have that collateral circulation yet. So one blockage, like in the left anterior descending artery, can cause death, immediate death, because there's no collateral circulation to get perfusion of blood to the myocardium. So somebody older might survive a heart attack at that point more. I'm not making that as a general statement, but this is what a widowmaker is when you have that one massive occlusion that you might not even see it on a stress test. And you're doing TRX, you're doing all these things, and you might exert yourself and you have this thing. It's pretty scary because of the lack of collateral circulation. Because as you get older, you develop more collateral circulation because you have to, because your heart is starving for oxygen all the time. Your heart will do whatever it can. Heart muscle will do whatever it can to get oxygen to itself. Yeah. So of course you can build up some cardiovascular growth by aerobic exercise, right? And it happens, you know, in adipose tissue when somebody's obese, right? So it increases the length of the vessel system, which increases peripheral vascular resistance, which increases your systemic blood pressure and puts a strain on the heart, right? The left ventricle has to overcome that. So you probably did a lot of this in lecture, blood pressure. So basically the blood pressure is the blood in the vessel against the walls of the arteries. And you can measure that. And it's a resistance too. So how much of that pressure can get through to the arteries. So the systolic is the high number. Like I said, I think this is what most books say. Systolic 120 millimeters of mercury. Don't forget, it's not PSI like your tires. And 80 millimeters of mercury diastolic. And let's see if you get this, if you spell this word later on. Sphygmomanometer is the cuff we use. So the diastolic is during your diastole, what you're feeling. And pulse pressure, again, you should probably, this is just the systolic blood pressure minus the diastolic blood pressure, which you probably did in lecture. And you probably have to do that today in the lab. So like you can do pulse, like even before you do blood pressure. Like if you look at an oscillator, you'll have systole, which is a pop, then diastole down, wave, trough, wave, trough. So you could see the pulse on an oscillator, but you could feel it. You know, you use your index finger and your middle finger. Don't use your thumb because your thumb has its own pulse to palpate a pulse. And you can use the radial artery down by the wrist, and you could feel what you're feeling is the trough. The waves, the peaks of the waves. And of course, it should be completely the same as your heart rate, right? If you already did heart rate on your EKG, the pulse rate should equal your heart rate. So that's really important. So the pulse pressure, though, is you know, the systolic minus the diastolic, but this is feeling the pulse. So you feel the waves of systole, and you count them. You could count them for 15 seconds and multiply them times 4. And you'll get the pulse rate because you're feeling the pulse, and you could feel that it's regular. You could feel if it's light or heavy or bounding, and then you can tell if it's fast, tachycardia, or slow, bradycardia. So it's throbbing, it's palpatory. You're using your fingers to feel it. And you can determine what the heartbeat is like and the regularness of it, not just the rate, right? So the radial is a good one. the common carotid, especially the internal common carotid, right by your SCM. You can get a femoral pulse up above the thigh. And dorsalis pedis, like that's all way down by the foot, right? And that should be the same feeling as you get from the common carotid at rest, as long as you have good arterial blood flow to the foot. So if it's missing, I mean, somebody can have very bradycardia or very low pulse pressure, and that you might not feel it so much. It could be normal for that person, but most of the time you should feel that dorsalis pedis pulse at the same rate and the same quality as the common carotid. With your fingers, don't forget, don't use your thumb. All right. So this is I have to spell this. The book do this for me. Spigot manometer is the cuff and the dial. Sometimes it goes on the wall. Sometimes it's a dial right on the blood pressure cuff. That's you can connect it or disconnect it. So what you do is you find the brachial artery first of all, and you get a pulse. Just get the pulse. See if you could feel the pulse. And before you even auscultate with the stethoscope, you could get the palpatory blood pressure. So you pump that cuff up. Let's say you expect somebody's blood pressure to be 120/80. So you pump the blood pressure cuff up to, let's say, 200. So it's occluding the brachial artery. So the brachial artery can't pump against that pressure. So you're not going to feel anything. And then you slowly let out the pressure out of the cuff. And once you feel the first pulse you feel, that's going to be your systolic blood pressure. And you keep feeling it, keep palpating it till you don't feel it anymore. Now, of course, the arteries overcome the cuff. So when you stop feeling the pulse, that's your diastolic. So the first pulse you feel is your systolic in millimeters of mercury, and the last one you feel is your diastolic. So that's palpatory blood pressure. Then you can do it with a stethoscope. Now you can listen to the beats coming from the brachial artery. Because if you're doing a stress test, sometimes it's easier when a person's moving and walking to do it palpatory, and you can't hear because the treadmill is making so much noise. So in this case, you do oscillatory if it's nice and quiet, which it should be. And you'll learn how to do it if you're going to be in a position, nurse or PA or any kind of tech that's going to do blood pressure. It's probably best to listen when it's quiet. But it's amazing how you could filter out extraneous sounds to hear this. So you pump up the blood pressure cuff again to 200. And the first sound you hear, which I don't know if I'm going to spell this right, is called the Korotkov sounds. And that's the beats. So the first sound you hear, the first beat you hear, you record at the 120, if you hear it at 120. And the last sound you hear, oscillatory, would be your diastolic. You're basically occluding the brachial artery, and the brachial artery is producing a pressure against the cuff, just like the blood inside the wall is putting it against the brachial artery. So that's really important. And this is another cool thing. This is about blood pressure in the different types. Now, we check the brachial artery. So the blood pressure is up in here, right? The aorta, of course, is maybe just a little bit higher, but it should all be equal. So we got a nice pulse here, pulse pressure of 40 going through. And you can do the mean arterial blood pressure by multiplying the pulse pressure and adding the third of the diastolic, right? And then you could look at the pressure dropping in the arteriole. So that's between like 40 and 60. In the capillaries, it's down about 20. In the veins, it's almost 0. In the vena cava, it is 0. So look at the change in pressures going from arterial system to your venous system. I like this a lot to look at this one. So we got measuring. So here's the mean arterial blood pressure is the diastolic blood pressure plus a third of the pulse pressure. So we have to add the diastolic because remember I told you before, diastole lasts just a little bit longer than systole because the ventricles are filling, right? So you get your pulse pressure, which is the 120 minus 80. and you get a third of that, and you add the diastolic. Okay, so your mean arterial pressure is like 93. So basically, this is what the left ventricle has to overcome to open up the aortic semilunar valve. Very important. And maybe in lecture you learned about ejection fracture, and of course you learned about stroke volume and cardiac output. So talking about the change, and I love that picture that was up there before. The arterial end of the capillary, the pressure is a little bit higher than the venous end, and then it goes down from there. So that's really important when you're going through the different pressures. Venous return we talked about earlier, because this is really important. Because at such low pressure, you need a good skeletal muscle pump. Like Todd said, you need to move. You need to contract those deep veins, or the muscles where the deep veins are, really, like your calves. There's such low blood pressure, from 20 millimeters in the ventricle, millimeters of mercury, to 0 in the vena cava. So the venous return is very important. It's a good example of your skeletal muscle pumps and keeping with the valves going in the right direction. And your diaphragmatic movement and your respiration also adds to the pump. When you're at rest, you know, of course, exercise changes all of this quickly, and the sympathetic nervous system helps as well. So the respiratory pump kind of gives that negative pressure in the vena cavas, which drives it up into the right atrium, which is really good. So sometimes the sympathetic has to increase your breathing rate to get a increase in venous return, right? And then the diaphragm, of course. Diaphragm lowers during inspiration and it elevates during expiration. So your breathing pump is really important for getting blood back to the right atrium. So again, just to repeat, and this is important, the pressure gradient from one end of a vessel to another. You can measure that. So this, I keep talking about resistance and peripheral resistance. So really the lumen size is the most important factor in increasing peripheral resistance, which eventually is going to increase your blood pressure. Vessel length could have something to do with being obese. And viscosity is the actual number of blood cells, like polycythemia is an increase in red blood cells. The opposite of anemia. So that could kind of gunk up the works and increase your peripheral vascular resistance and would increase your heart rate. But the lumen size has most to do with this. The polycythemia would happen, of course, if you're at high elevations, like when you're trying to climb Mount Everest, and there's low partial pressure of oxygen as you go up 10,000 feet, 20,000 feet, 30,000 feet. So your body thinks you don't have enough oxygen, so your red bone marrow is going to begin to produce a lot of red blood cells that are immature, really. They're not usable yet. It takes time. So your kidneys are going to release the EPO, the erythropoietin, which is going to target your bone marrow to make more red blood cells. And that's going to increase your blood pressure, which is very unhealthy. Unless you're a Sherpa who's living in Nepal your whole life and generations before that. That's a little bit different. So that increases the viscosity of the blood. That's what EPO is, blood doping. Like remember Lance Armstrong was using EPO, erythropoietin, as he was training in high altitudes, artificially, performance enhancing. So blood doping is increase in the number of red blood cells by release of EPO naturally, or it's worse if you take it yourself, abuse it. And that's blood doping, performance enhancing. So again, the vessel length, angiogenesis, increases peripheral vascular resistance, which is going to increase your blood pressure, right? And this is the most important, right, is the flow. Now, laminar flow, right, laminar flow. So again, that's more, maybe more lecture, but think about this, like about diseases and what could increase your blood pressure. Like, what's it called when you have like a lot of plaquing in your blood vessels? Sometimes it gets hard. Atherosclerosis, right, or arteriosclerosis. So what happens is, and if you have high blood pressure and your vasomotor or your tunica medias are always contracting, constricting, and if you have high fat diet where you have cholesterol running through your arteries and veins, you're going to injure the endothelial tissue, right? The lining, it gets injured, and macrophages are going to come in to try to protect that. And it's like an immune response, which we call inflammation. So you have inflammation within the vessel, and the macrophages are going into the endothelial tissue, and the LDLs, which are low density lipoproteins, which are high in cholesterol and triglyceride, low in protein. That's why they're low density. They build up in your arteries and injure your arteries. And that's an inflammatory response, really. And eventually it can cause something like a plaquing, like atherosclerosis. And if it's there long enough, it could cause arteriosclerosis, where it's actually the atheroma starts to calcify. So it could cause an occlusion in the vessel, like a coronary vessel, right? Coronary artery feeding the myocardium. And if you have occlusion of a vessel, you can have ischemia, which is decreased blood flow to the myocardium. And if you have ischemia, you can have injured myocardial cells. And they're going to start to fall apart until ultimately they may infarct. Infarction is a heart attack, a myocardial infarction. So that's how atherosclerosis. On top of that, you have high blood pressure, which is putting pressure on that atheroma and injuring more of the endothelial tissue, causing more risk of occlusion, more risk of cardiovascular problems like heart attack. And imagine if this happens in the brain, in a carotid artery that has atheroma, atherosclerosis, destruction and inflammation of the endothelial tissue. What is it called when you have lack of blood flow to the neurons of your brain and they can't undergo their synapses? They can't function. That's a stroke, right? A cerebrovascular accident due to that atheroma. So high blood pressure could cause something like that, like a stroke or a myocardial infarction. It's just bad news, man. It's just bad news. And it's like a snowball effect between the tachycardia from the heart, possible edema in the peripheral tissue, and edema in the lungs. It's just a heart failure all over the place. So blood pressure is scary, and you don't even know you have it, right? So the vasomotor center is more about sympathetic and the use of adrenaline, right? Norepinephrine, which is a neurotransmitter that goes to the vessels to make them contract, the smooth muscle. So your alpha adrenergic receptors, these are adrenergic only for this. In the heart, they were beta adrenergic, beta 1 adrenergic in the heart, beta 1 in the heart, alpha 1 in the blood vessels. So they're only sensitive, these receptors are only for norepinephrine. That's why they're adrenergic, alpha 1 adrenergic. Some are 2, and that would be a difference. That would be vasodilation. Now, what does that mean? Now, why would this happen? Remember me eating my burrito in the park, right? So, of course, my blood vessels are going to be excitatory with alpha 1, but my gastrointestinal system is going to be inhibitory because it's parasympathetic norepinephrine release. I'm sorry, it's sympathetic norepinephrine release. So that's going to stop my digestion. So it's going to cause more vasodilation to certain areas. Okay, so that's basically what I'm talking about, receptors. Again, I don't know if you have to know too much of that. And also the shunting of blood to different areas like your brain or to your skeletal muscle. So norepinephrine could have 2 different effects, vasodilation or vasoconstriction. Depends on where it's going. All right, depends on where it's going. So it's going to stop digestion, shunting blood away from the digestive system. Just a general rule there. So vasomotor, of course, increasing peripheral resistance, circulating blood flow, right, and redistributing to where you want it. So that's the takeaway. Again, that's probably more lecture. And baroreceptors. Again, I could talk about that for a minute. Just make sure where you're at. Do you know what baroreceptors are when it comes to the heart rate? You learned that in lecture. Cool. So that's baroreceptors are, like, it's, I like the metaphor of this. Like, say you're at home, you're living at home with your mom, and there's no food in the refrigerator. That's when you call her up and text her. You probably don't call her any other time. But if there's no food in the refrigerator, you're going to call them. So that's the way a baroreceptor works. If there's not a good blood flow to your carotid sinus or your aortic arch, then you send the signal to the sympathetic nervous system. Wait, we're not getting good pressure here. Send that a signal, and that increases your heart rate. So technically the baroreceptors, when they're not being stimulated, send the sympathetic signal ultimately. So think about me eating my mom's food 40 years ago in the refrigerator. I came from Italian family, so that thing was always packed, leftovers for 8 weeks, right? So that's the baroreceptor response. So let me just go through the EKG with you a bit before you go to the lab. See if I can insert a slide here first. Second. Of course, there's never a blank slide when you need it. Red bars and appendixes. Yeah, you just use this one, screw it. So EKG, now you have your baseline. You always read an EKG left to right because you got to see this thing. What's the first wave you see on an EKG? Anybody know? What's that wave? P wave. And you know what? It's got to be a sexy P wave, because if it's not a nice, round, sexy P wave, then it's not going to be sinus rhythm. It's going to be coming from somewhere else. So sinus rhythm comes from the SA node, right? Then you have a little bit of a negative deflection of Q, then a nice tall R, and a negative S, and then you get a T wave. So the P wave is, if it's sexy, is the SA node. So that's, will depolarize the rest of the atrial cells. So that's atrial depolarization. And that always happens first. That's why we're looking left to right. First. Whoa. So we get a nice sexy P wave, and then we have an interval between, interval is something that has bumps in it. So the PR interval between the P wave and the R wave should be normal too. And that should be between, I would say, 0.02 to 0.20 seconds. Now what's the next node that innervates the heart? Like, of course, you have the SA node, sinoatrial node, then you have the atrial cells. And then what happens next? Where's the next pacemaker of the heart after the atrial cells? Like what, the AV node, right? So now you have the AV node causes that little delay, which gives you a nice PR interval to allow for the ventricles to continue to fill until the atria contract. Yeah. Then you have this big, huge QRS complex. And that is what? That's Jimi Hendrix, right? And that's ventricular dipole. So all the sodium's rushing into those cells. So if you get a nice QRS that's upright R wave, the R wave should be upright, especially lead 2 on the EKG. You're going to have a nice ventricular depolarization, and you're going to have a nice ventricular systole to follow it, as long as the heart muscle's okay and the valves are good. So that systole continues a little bit to your T wave, and the T wave is what? Ventricular has to do what after depoles? Repolarization, right? So then you have, you get the ejection of the blood, and you have a nice stroke volume, and then it all starts again. It takes about 0.8 seconds if your heart rate is 75 beats per minute. You should see that every time. It's sinus rhythm. Like sinus rhythm means it's got a sexy P wave, therefore it's coming from the SA node, which is exactly where you want it to come from. And we call that normal sinus rhythm. And the heart rate should be between what? 60 to 100 beats per minute. And if it's below 60, technically that's sinus bradycardia. If it's above 100, it's sinus tachycardia. So the PR interval has to be normal, because if it's not normal and it's not sexy, you might have a different focus of pacemaking, which could be coming from the atrial cells. Like sometimes you'll see like a pointy P wave, not sexy, right? And then you have normal QRS though, normal T, but the P wave is messy looking. So this is not coming from the SA node. This is coming from the atrial cells. Now, why is the QRS still normal even though we have an ectopic focus, like a focus where it shouldn't be? It's not coming from the SA node. Why would that be normal? Who saves the day here?
AV node?
The AV node saves the day every time. Yeah, which is great. Sometimes you don't even have a P wave and you get normal QRS T. And this would be the focus of automaticity is coming from the AV node. Even the atrial cells aren't even working. Sometimes you have too much P wave going on and then you get a normal QRS T. Sometimes it's just a squiggly line of P waves, basically, not even P waves, and then a normal QRST. So this is what's called atrial flutter. Mega depolarizations in the atrial cells, and this is AFib, atrial fibrillation, which is barely even depolarizing. It's just out of control. And it's completely irregular rhythm. Like normal sinus rhythm is sexy P wave, normal rhythm. Every beat comes where it's supposed to. And this one, it's completely irregular. This one's regular. Flutter, atrial flutter is regular. But atrial fibrillation is definitely not normal and regular. It's a problem. And then you could have the AV node not even working. You get this big wide QRS. And it happens every time. This means the ventricles got to start their own. And you can have tachycardia, ventricular tachycardia. This is really bad. Now you're entering in a world where this is not sinus rhythm anymore. Because the AV node is not working here. The AV node can be blocked. So it's all about where the pace starts. And you learn this in lecture. You know that the pace starts in the SA node, then goes to the atrial cells, then goes to the AV node, to the AV bundle of His, bundle branches to the Purkinje cells. So that's basically the electrical part. Now, don't forget,